We are going to examine the underlying pathology, clinical presentation, and specific treatment pathways of anterior cruciate ligament ruptures. The human knee operates as a complex hinge. Unlike the hip or shoulder, which rely on deep sockets for bony congruence, the knee relies almost entirely on a network of soft tissue structures to maintain its stability under load. This diagram illustrates the bony architecture of the right knee joint. The femur, or thigh bone, rests atop the tibia, or shin bone. Deep within the center lies the anterior cruciate ligament. Notice its diagonal orientation, attaching the posterior femur to the anterior tibia. This precise diagonal orientation dictates its core biomechanical function. The ACL acts as the primary static stabilizer of the knee. This lateral vector model demonstrates anterior tibial translation, the forward sliding of the tibia underneath the femur. The ACL is anatomically positioned to physically arrest this specific movement. The joint places immense stress on this ligament during high-impact athletic movements. Pivoting, sudden changes of direction, jumping, and landing all force the ACL to absorb kinetic energy. The physical integrity of the ACL is the strict prerequisite for any multidirectional dynamic movement of the lower extremity. Without it, the hinge fails. Biomechanical failure occurs when external kinetic forces exceed the maximum tensile strength of the ligament. The collagen fibers simply snap. We categorize this failure into two distinct injury mechanisms: non-contact vectors and contact vectors. A classic non-contact injury involves rapid deceleration combined with a rotational cut, executed while the foot remains firmly planted on the playing surface. The fixation of the foot is a critical variable. When improper, overly long cleats lock the foot into the turf, the rotational torque cannot disperse through the ground. The force travels straight up the leg and into the knee joint. A contact injury mechanism achieves the same failure through direct trauma. A tackle directed laterally at the knee forcefully separates the medial joint space, stretching the ligament beyond its limit. This 3D physics model isolates the ACL to illustrate the lethal combination of forces. An axial load, combined with rotational torque, causes the ligament fibers to shear and separate. The ligament itself cannot be strengthened through training. Prevention relies entirely on optimizing the surrounding muscular system to absorb the shock before it reaches the capsule. Preventative conditioning protocols require a combination of cardiovascular fitness, targeted flexibility in the thigh and leg muscles, and coaching on proper biomechanical landing techniques. An ACL tear is a predictable mathematical failure. It happens when the kinetic load outpaces both the muscular defense system and the ligament's physical breaking point. Following a biomechanical failure of the ACL, the patient's immediate clinical presentation follows a consistent pattern. The primary diagnostic hallmark is sensory. Patients routinely report an audible or tactile pop felt deep within the joint at the exact fraction of a second the tissue tears. This is followed by rapid hemarthrosis, an accumulation of blood and fluid swelling inside the joint cavity. Hemarthrosis typically becomes evident within 3 to 8 hours post-injury. Acutely, the patient experiences functional deficits. The knee cannot be actively straightened into full extension, and any attempt to bear weight results in the joint buckling or mechanically giving way. Clinicians must immediately screen for injury comorbidities. Isolated ACL tears where no other internal structures are damaged are statistically rare. This top-down view of the tibial plateau highlights the C-shaped meniscus cartilage. About half of ACL ruptures present with a concurrent meniscal tear. The rotational force that destroys the ACL often simultaneously crushes and shears the meniscus between the bones. A meniscal tear introduces a specific symptom: mechanical locking. A fragmented piece of the cartilage wedges itself between the bones, physically jamming the joint mechanism. The failure of the ACL compromises the entire joint, resulting in a complex, multi-structural trauma zone where the stable hinge once operated. Treatment is dictated by a strict physiological constraint. The ACL has poor blood supply and sits bathed in synovial fluid, a joint lubricating liquid that actively prevents the ligament from healing on its own. An unrepaired torn ACL will often retract and aberrantly scar onto other structures within the knee, creating a permanent mechanical shift in how the joint functions. This decision tree outlines kinematic triage. The clinical pathway is determined by the intended future activity levels of the patient. The conservative pathway is suitable for individuals who strictly perform linear exercises, such as jogging, cycling, or swimming. For these patients, surgery is generally not required, and function is restored through targeted rehabilitation. The surgical pathway is required for patients demanding a return to multi-directional sports, like basketball or soccer. Without surgical reconstruction, the joint will buckle under rotational stress. The necessity of surgical intervention is dictated by the kinetic demands the patient will place on the joint in the future, rather than the severity of the initial tear. Regardless of the pathway chosen, clinical management begins with an acute phase designed to arrest the inflammatory cascade. This requires immediate application of cold therapy, 20 minutes every 2 to 3 hours, and the use of crutches to manage weight-bearing loads until the patient achieves a normalized gait without a limp. The pharmacological protocol utilizes acetaminophen for pain management. However, nonsteroidal anti-inflammatory drugs, like aspirin or ibuprofen, are strictly contraindicated if surgical reconstruction is scheduled within 7 days. Phase 1 of active rehabilitation focuses on safely restoring passive range of motion without exacerbating joint swelling. This biomechanical wireframe demonstrates gravity knee flexion. The patient allows their foot to slide down a wall, letting gravity passively bend the knee to achieve a stretch without requiring an active muscle contraction. The inverse is gravity knee extension. The heel is propped on a flat surface, allowing gravity to gently force the knee downwards into full straight extension. Phase 2 introduces isometric strengthening. By statically contracting the quadriceps and hamstrings, tightening the muscles without actually moving the joint, the patient builds muscular endurance without placing stress on the joint capsule. Phase 3 progresses to functional isotonic strengthening. These are weight-bearing movements through a range of motion, utilizing exercises like quadriceps step-ups and precise wall slides. During these exercises, strict joint alignment is critical. The kneecap must track perfectly in line with the second toe. This precision retrains the neuromuscular control required for stability. Whether the ligament is reconstructed surgically or managed conservatively, the goal of rehabilitation remains the same: engineering a dynamic muscular brace capable of compensating for a compromised static ligament.